So welcome and thank you for coming to this webinar. It's called the Eye and Ear Foundation Sight and Sound Bites. We do this bi-weekly to bring you highlights of the research at the University of Pittsburgh in the School of Medicine, particularly in these two departments, Department of Ophthalmology and Otolaryngology. Today's topic is a modern era of excellence in otolaryngology. I'm Lawton Snyder, CEO of the Eye and Ear Foundation. So the Eye and Ear Foundation supports this research that you'll hear about today to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the foundation support research and are only made possible because of the support that you provide. So we are very, very grateful to the donors who've come forward and those who are on the call who've helped us. As you'll see, it plays a very important role in really making things happen here to advance care for all these conditions. So just some housekeeping things. We do disable chat for this Zoom product. It's not going to be there, so don't try to chat with your friends. But we have a Q&A function. We really want you to ask questions. It's going to be important, and we all like to hear your questions, and Dr. Zevallos will get to those at the end. We're going to refrain from asking personal health questions if possible, but certainly if there's a question you have that you'd like to ask Dr. Zevallos or any of us, send it to the email that you get with your invitation, which would come from Craig Smith. And then feel free to use the subtitles below. Of course, we provide that for those who we know may need it. If you click on that, you'll see closed captioning as we present. And then you will be added to our mailing list for future presentations like this. Of course, you can opt out of that anytime if you like. So today's lecture is from Dr. José Zevallos. Dr. Zevallos is our new chair of otolaryngology. His title is Professor of the Department of Otolaryngology and the Eugene N. Myers MD Chair at the University of Pittsburgh School of Medicine. Dr. Zevallos started with us on August 1st. I've already really enjoyed and genuinely enjoyed getting to understand his vision and what he's bringing. You'll get to hear about that here right now. We're all very excited about the future of our already very good and very strong Department of Otolaryngology. And I'm, for one, extremely excited to see where Dr. Zevallos is going to help us, is going to take us. So with no further need for any additional introduction, I'm going to let you hear from Dr. Zevallos.
Great. Well, thank you very much, Lonnie. It's really a pleasure to be here with all of you to tell you about our great department of otolaryngology here at the University of Pittsburgh, and to really highlight how the foundation, the Eye and Ear Foundation, has been a central partner to this department and a big part of its greatness over the last several decades. I have been fortunate enough to be at the helm of this department for the last 3 months. I look forward to implementing a new vision that will introduce a new and modern era of otolaryngology and head and neck surgery to the University of Pittsburgh, and building, as Alani said, upon an already incredibly strong department. It's an exciting time here as we rethink or reevaluate and grow from our strengths and make it even stronger. So today I'll go over a little bit about myself, our department of today, what I see the vision and the mission of this department to be moving forward, as well as our values. We'll also touch on how we measure our success over the next several years. So my story. So I was born in Peru, in Lima, Peru. And when I was 7 years old, my father was offered a scholarship to go study engineering in England. So we all moved to England for about 2 years. My dad was there for 4. We were there for 2. My parents, who are both Peruvian, moved 3 kids one 7-year-old and 2 kids under 5 to a whole new country, whole new language, etc. Quite an adventure. We then moved back to Peru at a time where things were unstable because of terrorism in Peru. My father was then offered a job at Bell Labs in New Jersey as an engineer. So we all came to the US and settled in New Jersey. But we have ties, of course, to England because of the move. We have ties as well to Italy and to France. As I'll mention, my wife is half French. We have a lot of family in Italy. So we are a pretty international group across a couple of different continents. My brother now lives in Copenhagen. My other brother lives in Chicago. My sister in New York. So we're really all over the place, and we go to Peru very often. In terms of my training, I grew up in New Jersey. As I said, I went to college in Vermont at Middlebury College, where incidentally, even though it's known for languages, it turns out there are 6 active otolaryngology chairs right now across the country at academic centers who all went to Middlebury College, a very tiny school. I did my medical school in New Jersey at Rutgers, followed by my training in otolaryngology, head and neck surgery at Baylor College of Medicine, with time at MD Anderson Cancer Center, where I really learned about how to be an academic head and neck surgeon. And then I did a fellowship in New York City at Mount Sinai, followed by time at UNC Chapel Hill, which is on the faculty, where I really learned about some of the work I'll talk about today in epidemiology, where I really honed those skills and developed my research path. And then I was recruited to be the division chief of head and neck surgery and to run the head and neck cancer service line at WashU in St. Louis, where I spent about 6 years prior to being recruited to be the chair here at the University of Pittsburgh. So it's been a long road across the country, but I've really been blessed to have some incredible mentorship and support to get myself and my family where we are today here in Pittsburgh. So as I mentioned, I'm from Peru. I come from a family of doctors. I am the 8th doctor in my family, the first surgeon, I should note. Most of my family have been pulmonologists. My grandfather was a pulmonologist at the hospital you see in the middle there, called Zevallos in Peru during the heart of the tuberculosis epidemic in Lima. I have 2 uncles that have worked in cancer pathology at the hospital on the bottom there, which is the National Cancer Institute of Peru. My aunt, pictured here, is an internist in Germany. And my uncle at the very top is a pulmonologist in Dallas. And my parents, my dad's an engineer, my mom is a retired social worker. So my dad's one of 7 and the only one of 7 who didn't become a physician. My family is a big part of my life. I'll talk about them a little bit later. My wife, Juliet, my kids, Elena, José Miguel, and Luisa, as well as our dog, Zoe. And then my training, I really, as I mentioned, been fortunate to have some incredible opportunities to train with some of the legends of our specialty, including Bobby Alford, pictured at the top, who was a chair at Baylor, Randy Weber, former chair at MD Anderson, who I stay in close touch with, Mark Erkin, who trained me in my fellowship on reconstructive surgery, and then Jeff Myers, who is a son of Gene Myers. Gene Myers, of course, is our legendary former chair here in the Department of Pittsburgh. I'm honored to have his professorship named after him as my chair job. And his son has been a close friend and mentor to me for many years. So everything kind of rolls back to Pittsburgh one way or the other. My family, again, we love to ski. We're settling here in Pittsburgh. It's been a really fun ride for everybody. The kids are settling in well. My wife is happy, which is also very important, of course. And we're really enjoying our time here so far. So as I mentioned, I was previously the chief of head and neck surgery at WashU. I also ran a laboratory and was the principal investigator on multiple study protocols, including a couple of clinical trials. Importantly, I'm a head and neck surgeon. Even though I now have this leadership position and I'm an administrator to some degree, I will never stop being a head and neck cancer surgeon. Everything I do in terms of my professional career is defined by my experience taking care of patients, whether it be my research or my focus, my vision for leadership. The beauty of a position like this, in my mind at least, is that I get to help people through some very difficult times as their surgeon, but I also I'm able to implement a change and vision for the entirety of the department that has a much broader impact on patients beyond just my patients. And that's a big part of who I am as a surgeon scientist. Part of my job at WashU was to recruit and to really build up the translational science there. Overall, we went from $0 in NIH funding to about over $10 million in funding in our division over those 6 years. And I really did that by building the research infrastructure and by recruiting some very, very talented people to join the group. Part of my vision for Pittsburgh is to grow our department even more in the same direction. I also led the fellowship in head and neck surgical oncology at WashU, and I've trained some great young stars, as you can see here, who have gone on to great institutions in the last 5 or 6 years. I'm very excited about that as a big aspect of who we are, education. Our role in academic medicine is to do research, to, of course, to take care of patients first, also to educate the next generation of leaders in otolaryngology. And I'm very happy to be able to continue that mission here at the University of Pittsburgh. So my research, I began my research career doing a lot of work in epidemiology. Epidemiology is a study of how disease affects populations, so public health related issues. And one example of that recently, and I've shared this with Lonnie, is we looked at HPV vaccination across the entire country, veterans among the United States, and looked at veterans who were eligible for vaccination who weren't receiving it. And we found in this particular study that's going out for publication now that veteran vaccination rates were less than half of what they are among non-veterans. And this is an alarming finding, given that this vaccine will prevent many head and neck cancers, as well as other HPV-associated cancers. More recently, I've also developed some interest in biomarker development, liquid biopsy work. So we're using tumor DNA to evaluate the risk of recurrence of cancer in blood. And then we also started looking at that similar signal in surgical drain fluid. So when one has a surgery, they always have a drain that collects fluid from underneath the skin. That fluid for about 100 years has been thrown in the garbage as bio waste. But we discovered in my lab at WashU that if you really evaluate that fluid closely, you can find remnant cancer cells that can predict the risk of recurrence of the cancer. So what the surgeon left behind after surgery. And that's very important because it could hopefully one day allow us to define the next steps in treatment after surgery, radiation, immunotherapy, chemotherapy, by looking at this signal. In addition to my research career, I've become a founder of companies and an entrepreneur. Based on the work I just described, we started a company in January 2021. That's the only liquid biopsy company currently founded by a surgeon. I brought in a couple of co-founders who are exceptional, including Otolaryngology Chowdhury at WashU, and then Stan Lapidus is a legendary serial entrepreneur who invented Cologuard, invented the thin prep pap smear, which is the way pap smears are done across the world now, and founder of Exact Sciences. And then he introduced me to Teresa Tribble, who's our CEO up in Cambridge, Massachusetts, where our company is founded. And we're off to the races with this company. So it's been a lot of fun. And we're really advancing some of the research we started in the lab now into this commercialization space to try to get it to patients faster. I'm also an early member of a company called Vine Medical, which is a software robotics company based at Stanford in Santa Barbara, California. And maybe next time I'm on a webinar, I'll introduce a little bit more about them. We're still in a little bit of stealth mode right now, but exciting software robotics technology coming down the pike that will have an impact on the way we do endoscopy. So let's talk about the department of today. This is UPMC's Department of Otolaryngology. And as I mentioned, this department is really one of the strongest departments in the country already. It has a historic legacy that's built upon really Gene Myers, who was our first chair, and then Jonas Johnson, who was our second chair and my immediate predecessor. And they are both head and neck surgeons who really built this place into the premier place for research, innovation, clinical care when it comes to head and neck cancer. And in many ways, Gene Myers defined modern head and neck surgery for the rest of the world. Jonas Johnson, my immediate predecessor, also a very well-known head and neck surgeon who really has opened our eyes to the impact of treatment for head and neck cancer on overall survivorship for our patients. Of course, as we all know, the treatment of cancer is just the beginning of a journey that can go on for the rest of one's life, even if they're cured of cancer. And I think Jonas has been instrumental in allowing the community of head and neck surgeons to understand what the ramifications are of treatment with respect to quality of life, well-being of our patients, just well beyond simply surviving their cancer. We have a leading cancer center here, and we have the benefit of a very large healthcare system. The department also has been foundational in pediatric otolaryngology, skull-based surgery innovation, and neurootology. So it's really an incredible place to be with some really incredible people here who make this department very strong. So I'm very proud to be counted among this group of clinicians and clinician scientists as we look to build a department even more and make it even stronger. So this is the vision and the mission that I presented to the department as I started introducing myself and what I want to do here in Pittsburgh. And ultimately, our vision is very lofty, but as I've told others, there are very few departments nationally that have the potential to say they want to be global leaders. We already are global leaders. We just want to be the very, very best department when it comes to clinical care, innovation, research, education. And we're poised to do that now as we kind of enter this new era in the department. So we want to be the global leaders in surgical innovation, research impact, and training in otolaryngology, head and neck surgery. Our mission is to create a modern academic otolaryngology department that's focused on exceptional patient care first. And I think this is something I've stressed a lot. You know, we are an academic department with a tripartite mission, which is patient care, research, and education. But at the end of the day, we're here because we want to be good doctors to our patients. We want to provide exceptional patient care. Everything else we do is informed by the fact that we're here to provide excellent patient care. And that includes advancing our field through discovery and training the new diverse generation of Pittsburgh otolaryngology leaders. So we have an era of Pittsburgh leaders that defined the last era of otolaryngology outside of Pittsburgh internationally. And what I'm looking to do is over the next decade, create that next generation of modern leaders from Pittsburgh. So our values: patient care first, diversity and inclusion, accountability, and scholarship. And these are the things that really, as I talk to the faculty about where I want us to go, these are the four things that are going to drive us into the next era here. And what I'll focus on today primarily is scholarship. I think maybe other opportunities, I'd be happy to talk about our initiatives in patient care and diversity. But I think today I'll focus on scholarship, not only what we're already doing here at Pittsburgh, but where I hope to take us and some of the initiatives that we'll be implementing over the next several years. So what are our departmental priorities and initiatives? So as I mentioned, I'm very interested in understanding how we can improve patient care. And one of the things that really we often think about is that while we can create very, very novel and innovative treatments for patients, if we can't get patients to come in through the door and see the right doctor at the right time, at the right place, then the treatment that we're offering doesn't necessarily mean as much. So one of the things that we've talked a lot about through the foundation and with Lonnie and his team is how do we help patients better coordinate the incredible complexity that comes with tertiary care of anything. You know, in my world, it's head and neck cancer, but in other areas of voice or neuro-otology within otolaryngology, there's real complexity in navigating a very, very complex healthcare system in the United States. So we will be introducing an idea of patient navigators for our department. And the idea of the navigator would be to coordinate visits across this complex system. You know, with cancer, you have oftentimes 3 different services, 3 different physicians who are taking care of a single patient. And being able to overcome that, especially if you're traveling from a distance and all the resources required to make care successful, can be very, very challenging. We also are focused on bridging the divide between inpatient and outpatient. We can do a very complex surgery in the hospital in a controlled setting, but when patients leave the hospital, we want to be sure that they're ready for to face the challenges that come with their disease outside of the hospital, and making sure they take the next steps in their treatment in order to optimize their outcomes. So these are really important and central to our mission, is basically ensuring that patients are able to navigate this complexity of care. And some of the technology that we will be developing, robotic technology, other technology, is designed to improve that access and to improve touch points with patients, ensuring that throughout the journey of their treatment, whether it be, as I mentioned, for a voice problem, sinus surgery, head and neck cancer, cochlear implantation, that across the journey of their treatment for their disease, that we are able to make sure that when they need a doctor or they need a provider, that we're there for them. And I think we are in a position now, especially after COVID, to take advantage of things like telemedicine, other technologies to help us reach patients more often in a way that's makes their care and their the journey more efficient. Another thing that I'm very interested in doing over the next several years is aligning with the head and neck cancer research program at Hillman Cancer Center. We have among the leading head and neck cancer programs in the world here at the University of Pittsburgh Medical Center, the Hillman Cancer Center, and we are arguably the national leaders in head and neck cancer research, translational research. For instance, right now we have the chair of radiation oncology is focused on head and neck cancer. The chair of otolaryngology, myself, I'm focused on head and neck cancer. And the cancer center director, Bob Ferris, pictured on the top left there, is also a head and neck surgeon. So nowhere else in the world do we have such a focused attention in the leadership of this cancer center on head and neck cancer than we do here in Pittsburgh. And I think that's reflected in how we, in the research we do in this disease. We have a SPORE. A SPORE is a highly coveted and very competitive programmatic grant from the NIH, from the National Cancer Institute, to help fund programs that have promise in really moving the needle on curing head and neck cancer. There's only 5 in the country, and we have one of those at Pittsburgh. And that allows us to build an infrastructure to support translational researchers, clinical trials. And my job as a department chair is to complement those existing resources by building up the infrastructure, by recruiting the best people to work in the SPORE program and take our research to the next level. And as we work together with Bob Ferris and with Heath Skinner in radiation oncology and the rest of the team, we're really poised to be the best clinical and translational research program in the entire country. And as I think about what I can contribute to this program and what I hope to do and aspire to lead as part of this incredible network of researchers and clinicians already, one of the things that I'm very excited about is growing the population sciences, the public health aspect of head and neck cancer. So as I mentioned, head and neck cancer care is incredibly complex, and folks who are coming from a distance or who don't have the same advantages as others socioeconomically can have an incredibly difficult time in getting the right care, getting access to care early enough that is curable. And so I'm hoping to take the skills that I've acquired over the years in my research, as well as through recruitment, to build a population sciences center in head and neck cancer. And our goal would be to better understand the barriers of access to head and neck cancer care. Also understanding disparities in care, why certain populations receive better care than others or have better outcomes than others. And then, of course, improving primary and secondary prevention of cancer. So primary prevention is things like HPV vaccination, smoking cessation. Secondary prevention is things like early detection of cancer. So once we have a cancer, how do we intervene early enough to prevent it from being as bad as it can be? And our vision is to use and leverage our healthcare system to build a population-based approach to understanding head and neck cancer. So Angela Mazul, who you see here on the right, is my colleague at WashU, where I previously was. I recruited her from UNC to WashU, and now I'm recruiting her to join me here in Pittsburgh. And she is a head and neck cancer epidemiologist who has been funded by the National Cancer Institute. And her task will be to build this population-based cohort study. And the idea is once we build this study, then if we have questions around understanding rare head and neck cancers or understanding why people who don't smoke get head and neck cancer, we're not relying on just a single institution in Pittsburgh to help answer these questions. We get the power and the benefit of an entire system that encompasses most of Western Pennsylvania to answer these important questions. So that's part of what we did in North Carolina as part of the CHANCE study. And that's part of what we will do here in Pennsylvania to better understand our community and better understand how head and neck cancer manifests in our community here in Western Pennsylvania. So in addition to that, and related to that, we have access to clinical data analytics. So we have a data-rich environment to understand why certain patients don't receive care on time, why certain patients have delays between surgery and radiation, for instance. And we should leverage this, and we will leverage this to understand and answer these epidemiologic questions about prevention and building the studies, as I mentioned here. In the HPV vaccination program I did at the VA, we can readily mimic that program in UPMC and within our Western Pennsylvania cohort to understand how we can improve vaccination for eligible men and women to prevent cancer. And to give you an idea, in the VA system, we found that currently $75 million are being spent a year on preventable cancers, right? So I think it puts into scope the extent of this problem. The majority of HPV-associated cancers now in the United States are throat cancers or cancers that I treat. And we need to do a better job, not just at creating incredibly novel immunotherapies and new treatments for this cancer, but we have to be better at preventing this cancer, especially given that we have a tool that will prevent these cancers. And it's a matter of us having the courage and the willingness to really implement these tools into our population. So switching gears a little bit from head and neck cancer and from what we hope to do there to hearing sciences. One of the things that attracted me primarily to this program when I was looking at this chair job was the incredible program we already have in place in hearing sciences. So we have the Pittsburgh Hearing Research Center, which was started 5 years ago here in the department, led by Dr. Thanos Sunopoulos. And these are PhD doctors, so they're not MDs, they're scientists. And their entire focus is understanding why people have hearing loss, why people have tinnitus, and what we can do about it. So it really has become among the top three, maybe even the top department for hearing sciences in the entire country. So why are we doing this? The reason is because hearing loss is a major unmet basic science and clinical need. Many of you may know that hearing loss is tied directly to dementia. And approximately 1 in 3 people in the US in their 60s and 70s have hearing loss, and nearly half of those older than 75 have hearing loss. And it's the most common modifiable risk factor to dementia. So if you can't hear, then your isolation increases, your cognition decreases, and ultimately can be a major factor that we can modify in dementia. So it's our role as otolaryngologists to not only help this through care, through providing cochlear implants or hearing tests or hearing aids, but also to understand the basics, the biology behind hearing loss and what we can do about it. And that's really the mission of the PHRC. As I said, it's a massive clinical need. 50 million people in the country suffer from tinnitus. Among the VA system, tinnitus is the highest service-collected disability. And I think it's time for us to address some of these difficult problems. Now, hearing loss and tinnitus have been difficult in the past to address. We have new tools that are being developed clinically for this, but what we're focused on in the PHRC is understanding what we can do scientifically to really understand the basis, the foundations for why people lose their hearing or have tinnitus. And what has the PHRC done? And I can't take credit for this. This is what's been done before my time. We've hired now 3 really great researchers to the group who all have funding now from the NIH, competitive funding. We have almost $4 million in grants, 45 publications, which are getting our science out to the community, and 4 patents. And what I challenged Thanos, the leader of this group, to do when I arrived here is to think what's next. We've reached many of the milestones already in terms of academic productivity, but what else can we do? And what else we can do is try to translate our discoveries as quickly as we can and as safely as we can to improving the lives of patients. Again, everything we do, whether it be this or our head and neck cancer research, ultimately is tied back to improving the lives of our patients. So what we've done is we've built and we're building a group that is basically an incubator for developing translation and commercialization of these discoveries into products that can be helpful to patients more quickly. And we have a good plan, I think, for this. There are really 4 major areas where we can make an impact. And I'll tell you 3 of these areas we already have covered incredibly well. Therapeutics for tinnitus. So Thanos and his partners in the pharmacy department here have developed a new drug that may have an impact on reducing tinnitus in patients. So this is ringing in the ears of patients. And I think they're working with UPMC and they're working with our School of Medicine to take this drug and really refine it to a point where it can have real impact on patients. Neuroprosthetics to improve cochlear implants. So many of you may know about cochlear implants already. These are devices that are implanted within the cochlea, within the inner ear, to assist with hearing loss. We have an investigator here, Dr. Insinali, she has been working on creating these direct feedback loops to improve how cochlear implants work. So we have clinical trials that we have planned for the future and hope to move that forward as well. Gene therapy is a very exciting area, not only in hearing loss, but in vision loss and in other conditions, where we now have the ability to delete or include genes that may be damaged or may be missing to help restore function. And we've had some really interesting data developing around gene therapy for hearing loss under certain conditions, genetic conditions that lead to hearing loss from birth. And then finally, we're actively recruiting, with the help of the foundation and with the help of the School of Medicine, a new investigator who does what's called hair cell regeneration. These hair cells are these tiny cells within the inner ear that transduce mechanical vibrations, which are sound from the eardrum, transduce them to electrical signal that goes to our brain. And that transduction happens by these hair cells. And when these hair cells are damaged from hearing loss, if you can't regenerate them, if they're gone, they're gone. And so we're looking for ways of regenerating hair cells to restore hearing. Very, very exciting work by one of our recruits who we hope to attract here in the next year or so to join the PHRC. And as Thanos mentioned, another benefit of having this department here at Pittsburgh is that we have an incredibly strong world-class ophthalmology department as well. And some of you may know José Alain Sahel. We share the same spelling of our name, our first name, which is interesting. And José Alain leads ophthalmology. He's a world-renowned researcher in ophthalmology from France. And we have the opportunity to collaborate. And what we're actually working on first as a collaboration is a joint PhD program that looks at hearing and visual sciences. There's a lot of commonality between hearing and vision. And in terms of how the nerves work, in terms of how we translate an external signal, whether it be visually or audio or through hearing, into a signal in the brain. So that pathway is very similar in both of these different disciplines and areas. So we think that there's an opportunity for us to create a graduate program, a PhD program, focused exclusively on bridging those gaps within anatomical and functional components of the auditory system, speech and visual pathways. And as I mentioned, there are neural mechanisms of perception and cognition. And so we're working together actively. We have a meeting actually about this with the dean tomorrow to help move this along. And it's an exciting collaboration that we will be doing to increase our educational offerings here at Pittsburgh and join between these two departments. And then finally, another area that I'm very interested in, as I mentioned, I'm an entrepreneur, I'm an inventor, in addition to my day job. But we have a system here called CREATES, which is a program that was started several years ago by my colleagues, Dr. DeVury and Dr. Snyderman, with the intention of being the bridge to industry, to responsibly engage with our partners in industry in order to innovate and create new technologies. And they have provided industry with incredible knowledge from our world-class surgeons here on how to build their products. What I hope to do with this group is I want to focus not so much on building up the companies that come to us with established products to help them validate, but I want us to be the inventors as opposed to the early adopters. And so we're going to redesign CREATE. So we're going to work with the CREATE leadership to focus more and more on generating our new ideas, our new inventions, and providing this to the world. And I think CREATE is a perfect platform for us to do that. In addition, of course, to doing our mission in surgical education. So I'm excited to partner with these two surgeons in my department to really make this a reality over the next several years. So I want to thank you for your attention. It's been fun to share my vision for this department and what we aspire to do over the next several years. I've now shared that vision with the dean and the faculty here and the residents. the foundation. And I'm really excited to share it with you. And I'm very happy to answer any questions that you may have. So thank you very much for your attention.
Oh, wow. Thank you, Dr. Zevallos. Thank you so much. And again, welcome to Pittsburgh. It's wonderful to hear this, but it's also exciting that, everything that you just spoke about here is really building on the past, but also seeing and building on the strengths, but also really, I think, driving a very, very important new direction in many ways that we all are looking forward to doing and doing with you as a partner. That's great. Thank you. So we have a bunch of questions, and I'm going to encourage everybody to continue to give us some more as we have Dr. Zevallos here with us. But just something I felt like I wanted to ask, and it's just something that related to this whole HPV related cancers. For you as a head and neck cancer specialist, is it frustrating that we have something that prevents cancer, a vaccine that prevents cancer, and that obviously this still is on the rise and we're still seeing
right. Yeah, it is very frustrating. I think one of the challenges about it is that these cancers are unique in that they're caused by a virus. We have a way of preventing the virus infection, and really HPV gets this, has, because of the nature of HPV and the fact that in some cases it's sexually transmitted, there's a stigma around HPV. But the reality is HPV is incredibly common. And, if you look at, maybe 40% of all US adults have some form of HPV or have had one in the past. So it shouldn't be something that should be so stigmatized. And it really is incredible how effective this vaccine is at preventing infection and therefore preventing cancer. So I think the frustration could be frustration for the sake of frustration, or it could lead us to actually act, right? And I know the foundation, the Ioneer, has been instrumental in moving the needle on that here in Allegheny County. What I hope to do is harness that frustration for us to figure out ways of actually educating people about the importance of this, especially parents who have young children. But as our audience may know, the vaccine is now eligible. People are up to age 45 are now eligible for the vaccination, right? If you talk to your doctor, you can get vaccinated up to age 45. So the population of people who we can help is now much broader. What we don't understand yet, and part of the work I'm trying to do, is how do we connect with people, with adults, with parents, and with young adults about the importance of this without overly stigmatizing this as the social aspects of this really should be put aside for a moment. So I'm finding ways of harnessing kind of my frustration or our frustration with the preventable cancer into finding interventions that we can hopefully propagate and therefore improve these outcomes.
Well, the first question is kind of a good lead to that. Do you think that lack of HPV vaccination is due to vaccine hesitancy, lack of awareness, or other factors?
So it's a great question. I think early on, I remember I was in Texas for my training when the vaccine was becoming more popular. And there was a lot of social, it was linked to things like promiscuity or things, things that were more sexual in nature when they probably shouldn't have been, right? And I think that set off this idea that this was somehow the act of vaccination was a social issue as opposed to a health issue, right? And we know now very well from the COVID experience that somehow vaccines become the lightning rod for social issues and for reasons that are really unclear why somehow these vaccines have taken on this role in our society. But going back to this, I think if you look at the science is very, very strong that this vaccine prevents cancer. And we should think about it that way. It's not an HPV vaccine, it's a cancer prevention vaccine. And if we frame it that way to our friends and to our families, I think it has a lot more resonance among our folks. And the other thing is that this cancer previously, people didn't want to acknowledge that even things like head and neck cancer are caused by HPV. Now, head and neck cancer is the most common kind of HPV-associated cancer in the United States and occurs 90% of the time in men. right? So I think the landscape has changed of HPV cancers. And I think we have to frame our messaging to keep up with the changing epidemiology.
That's certainly, I think we all agree in everything that we've learned over the years. We appreciate that so much. And again, want to continue to support you in all those efforts.
Yes. Yeah.
So access to care has become a hot topic in healthcare. What's the department doing, or what are you hoping the department can do to address access to care as it relates to ENT?
Right. It's a great question. I think it is a hot topic, and I think it's always been an issue, but now I think we're actually finding ways of studying it and how intervening. And Lonnie and I and Carrie have talked about this a lot, that what I hope to do is transition from describing access issues, which is what most of us are doing right now, or what we tend to do in academics is describe a problem, to actually finding solutions for intervention to improve it, right? And it's a change in mindset that we have to do now. The reality is, for us to make an impact on this, we are, even though we're one of the biggest ENT departments in the whole country, and we have international reach, compared to something like internal medicine or primary care, we're really not a very big department, right? Internal medicine is a massive department, family medicine. So we have to all partner together to move the needle on access. And I think within our region, we can do that through, we've talked about community healthcare workers. That's an initiative that the foundation is doing now. And I'm looking for opportunities for us to leverage that system to get to more people and get them in the door when they need to come in the door. So it's a work in progress. I think what I hope to do is, through our population sciences work, is first understand the problem before we can start implementing how we change it. That's really our first step.
That's wonderful. So next question is related. It says, love to know more about the Patient Navigator program. I've often find it difficult to navigate the system on my own. That's just because it's so hard to park here.
Yeah, well, and that's a great point. I think this is not just the person who raised this. It's really a universal problem, right? And parking is maybe the most obvious or the most in your face access issue, but there's a lot more that comes behind that, right? And I think what we have to do, and this is something I think a lot now, we have, at least in our system, the benefit of having a massive system. And we have to question whether or not the care that one needs at any given time is best at. We shouldn't necessarily provide care for every disease at every place. There are opportunities for us to use our system to diversify where care is being provided, to make access better. The Navigator system, I think, is something that's near and dear to my heart, because I've used navigators. We've had navigators in my previous job. We had a great one at MD Anderson. And having a person who is responsible for all of these pieces, for knowing when to get to your appointment, recognizing the importance of being on, getting your treatment done by radiation and medical oncology on time for cancer, for instance, is essential. And I've found, there's all kinds of technologies that one could develop to send automated text messages to people, et cetera, to do reminders. At the end of the day, though, the human touch is important. You have to have a human being who cares, who's driving the complexity of care for patients, because you're overwhelmed with a cancer diagnosis. It's a life-changing event. And the last thing you want to worry about is, do I have to do 2 appointments across the city, or how many CT scans do I need, et cetera, et cetera. So if I can have somebody who's responsible for ensuring that the patient journey is easier, I think that's what we're after. And that's what the foundation is going to help us partner with.
Terrific. So I understand that there's a strong head and neck cancer reconstructive surgical team. And how does a team like that help patients regain their lives?
It's a great question. So I think one of the facts about head and neck cancer, which I think about a lot, is that if you look at advanced head and neck cancer survival prognosis in the 1970s, and you look at the same cancer type today, the harsh reality that we all have a hard time facing is that the overall survival of the cancer hasn't moved in all those years. If you have a T4 larynx cancer in 1970, and you have a T4 cancer of the larynx today, your chance of survival is the same. And I hate to say it, and I hate to admit it, because it means that we haven't made many strides in terms of understanding the biology of this cancer or treatments. And it also inspires us to do more. Where we have made a big impact is on the reconstructive side. We have expert head and neck surgeons who do reconstructive surgery that provide patients with restoration of function. Now, let me be clear, you can't restore what was there before perfectly. We just can't do that. But we certainly have made incredible strides in providing patients with the opportunity to be in settings that they feel comfortable in without the deformity of really, after aggressive cancer surgery. And if you think about it, we deal with cancers that are really in your face, in terms of everything we do, whether it be speaking or swallowing or going out to dinner and eating with your family. These things, when you have a head and neck cancer, are front and center. We're impacting the things that make you a human being. We're impacting the way you interact with your friends, with your family, your ability to go to a restaurant. You can't hide head and neck cancer. You just can't hide it, right? So even if we come 60% of the way in reconstruction, 70% of the way to getting you back to that function, then we've done a big difference for our patients and the quality. It's a huge part of our specialty because we care not only about surviving the cancer, but of the quality of life for our patients.
So how did you decide to become a head and neck cancer specialist?
Good question. So I went into medical school thinking I'd be a neurosurgeon, I think it was, or maybe a cardiologist, something intense like that, and without knowing anything. Like I said, I come from a family of internists primarily, and my uncle in Dallas was pushing me very hard to become a pulmonologist and go take over his practice in Dallas. And so I went down there a couple of times and did the whole pulmonary function test thing. And I'm like, this is not for me. I'm going to be a surgeon. And the reason is because I really enjoy being able to fix a problem, right? And fix it myself. And that's the mentality of, I think, surgeons is, there's a problem there. I can do something actively and I can resolve the problem, right? So that was what drew me to surgery, I think, to start. And then with respect to head and neck cancer, we do, like every first year medical student does, an anatomy lab, cadaver lab, where we learn, really from our first patient. That's our first patient. And we learn all the anatomy of the body. And I was just blown away in my third week of medical school by the anatomy of the head and neck, the nerves and the arteries and these critical structures that, like I said, make us human beings. We're all in such close proximity to one another. And it's such a delicate, elegant anatomy. And that's always something that has inspired me from the time I was a first year medical student.
So many of us have followed the tinnitus and hearing research in the department. Is this going to remain to be a focus under your leadership?
Yes, it is. And it's as I've told others, I'm doubling down on this research. Not just are we going to continue it, but we're going to nurture it and grow it. And that's part of our recruitment strategy. That's part of our translation into taking these ideas and making them into products. It's a big part of who I want us to be. And I think even the PhD program, attracting talent, is along the same lines. So I think Thanos' work has been exceptional and really leading the country on tinnitus research on something that's a frustration for so many people. And I think we will remain really, really engaged in moving the needle forward in that space.
Well, I think we're all appreciative of that for sure. Mm-hmm. Are there preliminary screenings one should get for head and neck cancer, like other forms of cancer?
Great question. So there are no recommended screening systems or protocols for head and neck cancer in general. So the dentists tend to do a screening when you go to the dentist, and I think that's helpful. It's not hurtful, obviously, but there's not really a recommended, validated screening mechanism for doing so. I think, though, doing a complete oral exam like you would get by a dentist or even by a primary care doctor should help in terms of detecting things early. The most important thing I tell people all the time is anything that persists in your mouth or your throat for more than 3 weeks and doesn't get better, you should go see somebody. Go see your primary doctor or see an ENT doctor like one of us. The other thing is that a neck mass in an adult, always that persists for 3 weeks or more, has to be evaluated, right? You can't pass it off as an infection. You can't pass it off as, anytime there's a neck mass in an adult that's there for more than 3 weeks, that should trigger a visit to an ENT doctor. So I think understanding those aspects of things can hopefully get us to, earlier prevention or earlier detection.
Well, I can tell a Pittsburgher asked this next question. Was your decision to come to Pitt mostly about the department itself, or what about the city drew you to the job?
Yeah, great question. So I had actually never been to Pittsburgh before this job. Of course, I came about 4 times, during the course of the year that I was going through all the rounds of interviews for this position. I was, so it was primarily about the legacy of the department. But what I've been so happy about is, as I got to know Pittsburgh, is how great of a city it is for families, for having a city that's small enough that you tend to know everybody everywhere you go. Even we already meet people that you know already, but also having everything that this city has to offer with respect to sports and arts. That combination of a small city that's livable with all the culture and all the sports is really hard to find. I think St. Louis did an okay job at it. I think Pittsburgh does a better job at it, frankly. And I'm not just saying that because I'm here now. I think it's really been remarkable and fun. The only complaint I have is the traffic on Route 28. And there's, I live up in that area, and man, it is something else. So I'm also learning about the fact that you don't want to spend too much time crossing bridges and tunnels. So I'm getting there, but we've loved it so far. We've been to a Steelers game already, thanks to Lonnie and the foundation, Bruce, and then we've also been to a Pirates game, and we went to see the Pirates versus the Cardinals, which was interesting, and the Pirates won that night. So it's been a lot of fun so far.
All right. Well, we have another clinical question here, and then one that's more fun. What is the upper age level in which you would do cochlear implant with a senior citizen who has profound hearing loss?
Interesting. That's another great question. This audience has some really good ones. So I commend you. I don't do cochlear implants myself. I'm a cancer doctor, and we have wonderful audiologists and otologists here who may have more insight. I can tell you, generally speaking, age in and of itself isn't a reason why we don't do an operation. It's, there's plenty of people who may be in their 80s who are healthier than some 40-year-olds, right? So I think the calculus isn't just about age. It's not really an age cutoff per se. It's more about the combination of the whole person, age being one component, the health being another, all the aspects that come along with cochlear implants, because cochlear implants is not, a one and done type of thing. It takes quite a bit of work in terms of understanding how the cochlear implants is used and how to maximize the benefit. So I think it's much more complex than just saying that there's an age cutoff. But again, I don't do that surgery, so we'd have to refer you to Dr. McCall or Dr. Perez to really give us some insight.
All right. Well, last question of the day, but I appreciate this for sure. So Eugene Myers equals Chuck Knoll, Jonas Johnson equals Bill Cowher, making you the equivalent of Mike Tomlin to the department. Is there pressure carrying on the tradition and legacy of the department, or is that challenge something you appreciate and thrive on?
So I've been asked that a lot, as you can imagine, because I have big shoes to fill. I don't dwell on the pressure part. What I spend my time thinking about is leaving a mark over time that's going to improve the department for the better, right? And in many ways, the reason why the pressure part isn't a huge part of what I'm doing is because I actually have the benefit of having Dr. Myers, who I have lunch with every 2 weeks, and knowing his son well from MD Anderson. And I have the benefit of having Dr. Johnson, who has an office across the hall from me. So these legends are actually people who can provide wisdom and insight, and who understand what this department is and where we can head. And having their support has alleviated some of this idea of pressure or whatever. I think we're I think my enthusiasm and energy would be a better way of defining how my sentiment in the department. But I'm not going to kid you. I do sense the enormity of this position. And I think that became very evident when I was named the chair. And I heard from an entire country, people telling me, this is an incredible opportunity to really lead the field again from Pittsburgh. And I don't take that lightly. This is become my life's work, is to be the chair of this department. More important than my individual success of any kind is the department success. And as long as I keep that as the North Star, I think we're going to be in good shape.
Well, I would love to end on that, because that's certainly a wonderful ending. However, we did have another question slip in a minute here. So why is there such a low upper age limit for the HPV vaccine?
Great question. So, originally the vaccine was really only for adolescents, for pre-adolescents, actually, for girls up to age 12. And that was based on the fact that at the time, there was only really a knowledge of HPV cervical cancer of the cervix being the primary HPV-driven cancer in the US. Over the last 15 years, however, we've determined now that because of pap smears and other things, there's been a huge prevention of cervical cancer, but there's been a huge increase in throat cancer caused by HPV. So it's now the most common cause. And there was a lot of debate about increasing the age limit because some people thought, well, once somebody is sexually active, there's no benefit to the vaccine. But it turns out that may not be right. There's been studies showing that up to age 27 for sure, the vaccine has a public health impact. It can reduce overall population cancer levels. Up to age 45 is a little bit more controversial, and there's people who are studying that now. But I guess the rationale has been from the CDC, as long as your doctor agrees with this, there's not much harm in most people as a precaution to do the vaccination up to age 45. But the data are most solid below the age of 27. The 28 to 45, the data aren't as clear, but there's also not harm, right? And that's the calculus whenever we have a public health intervention, is benefit and cost versus harm.
Right. All well said. I guess it is an appropriate way to end. But let me just say again, welcome to Pittsburgh. And
thank you.
And it's an honor for me, and it's an honor for our team from the Eye and Ear Foundation to have the responsibility and the privilege to be able to work with this department. And it's wonderful to have you as a new leader. We're really again excited about all that we have looking forward. And we still get to work with our very good friends like Dr. Johnson, who's going to be continuing to do what we're doing. So thank you. And this was really fun to be able to do this with you today.
Thank you, Lonnie. And I want to just reiterate how vital the partnership is between my department and the Eye and Ear Foundation. We would not be where we are now, and we're not going to be able to implement this vision that I just laid out without the support and strength of the foundation. So thank you very much. It's been a pleasure to be here and to chat with all of you.
Thank you, sir. Have a good day.
You too. Thank you.